Welcome to Board Pearls. This is episode 3 of 5 of the chronic pancreatitis, cysts, and neoplasms chapter in the pancreatic and biliary disease module. This episode is autoimmune pancreatitis, types 1 and 2, told apart by their mechanism, demographics, imaging, serology, histology, and steroid response. The chapter so far has stayed inside the alcohol and tobacco gland, the patient with calcifications, ductal stones, a dilated duct, and the pain and exocrine consequences of fibrotic replacement. This episode steps outside that gland to a diagnosis that sits at a costly decision point: steroids for autoimmune pancreatitis, and a patient who actually has adenocarcinoma delays curative surgery, so the whole framework is built to make the call on data rather than impression. Start with autoimmune pancreatitis, where the mechanism splits the entity into two clinically distinct diseases that share a name. Type 1 is a plasma cell disease, where the pancreas is one of many organs the IgG4-related fibro-inflammatory process can involve, so the same biology shows up in the bile ducts, salivary glands, kidneys, retroperitoneum, and orbit. Type 2 is a duct-centered disease, where the injury is granulocytic infiltration of the pancreatic duct epithelium. The process is confined to the pancreas, and the systemic immune signature is absent. The demographics fall out of that. Type 1 is a disease of older men, around 60 to 70, 3 times more often male, presenting with painless obstructive jaundice, and that absence of severe pain is itself a clue, because IgG4-driven fibroinflammation compresses rather than dissolves, so it produces the jaundice of a head mass without the necroinflammatory pain of acute pancreatitis. And if the stem leads with severe epigastric pain in this demographic, the diagnosis is probably not type 1. Type 2 is a decade younger with an even sex distribution, presenting as recurrent acute pancreatitis or a mass. And its other defining feature is the inflammatory bowel disease comorbidity, because about a third of type 2 patients have it, usually ulcerative colitis. And that association is a signature you don't get from imaging or serology. Imaging comes next. Type 1 classically shows diffuse sausage-shaped enlargement with a hypoattenuating rim, the capsule sign, in a minority of cases, while most show a focal mass that looks like adenocarcinoma on cross-section, but the duct is the tell. Adenocarcinoma obstructs the duct and produces the double duct sign with upstream dilation of both the pancreatic and bile ducts, whereas type 1 infiltrates the duct rather than obstructing it, so the duct is narrowed but not dilated and there's no double duct sign, and a sausage-shaped pancreas with a capsule rim and an irregular but non-dilated duct nearly makes the serology adds a layer because IgG4 is elevated in most type 1 patients and uncommon in type 2, but the trap is sealing the diagnosis on a single value because a mild elevation, under twofold, also occurs in some pancreatic adenocarcinomas. So an IgG4 of 180 in a patient with a focal head mass and jaundice does not establish autoimmune pancreatitis, and the threshold that actually supports it is greater than 2 times the upper limit of normal, and even then it's one criterion among several. Other organ involvement is the next criterion and often makes the call, because the pancreas doesn't get IgG4-related disease in isolation, so the patient with submandibular gland swelling, periorbital pseudotumor, retroperitoneal fibrosis, or renal infiltrates on a scan done for another reason has the supportive evidence that turns an ambiguous mass into a confident type 1 diagnosis, and while its absence doesn't rule the disease out, its presence is highly supportive. Histology resolves the cases where imaging and serology disagree. Type 1 shows a lymphoplasmacytic infiltrate, storiform or whorled fibrosis, and obliterative phlebitis where the infiltrate destroys venous walls, with the defining stain being more than 10 IgG4-positive plasma cells per high-power field, while Type 2 shows the granulocytic epithelial lesion, a neutrophil-rich injury of the duct epithelium, with fewer than 10 IgG4-positive plasma cells per field, and none of Type 1 storiform fibrosis or phlebitis. Those 5 elements, histology, imaging, serology, other organ involvement, and steroid response, make up the diagnostic criteria, and they're so structured because of the differential with adenocarcinoma, since both present as a focal head mass with obstructive jaundice, and the cost of treating an undiagnosed cancer with Prednisone is losing the resection window, while the cost of resecting an undiagnosed autoimmune pancreatitis is a major operation for a steroid-responsive disease. That's why the criteria pull the steroid response in as a diagnostic element and not just a treatment endpoint. Both types respond to Prednisone 40 mg daily for 4 weeks, then a taper of 5 mg per week, with clinical and biochemical improvement within 2 weeks being part of the criteria, because the mechanism is suppression of a fibroinflammatory infiltrate that's reversible early and progresses to fixed fibrosis if left alone, so failure to respond within 2 weeks is the signal to reevaluate for adenocarcinoma, and that reevaluation is the rule that prevents an empiric steroid mistake from continuing past the point. There's one setting where the steroid trial doesn't get to be the test. When the non-invasive workup leaves the differential genuinely unresolved, surgery takes precedence. The classic stem is a focal head mass with a double duct sign, a Ca 19-9 in the hundreds, a mildly elevated IgG4, and a biopsy without storiform fibrosis or phlebitis, where the temptation is to give steroids because the IgG4 is up, but the correct move is resection, because empiric steroids cost the resection window if it's cancer. The features that actually buy the steroid trial are an IgG4 over twice normal, the diffuse sausage-shaped pattern, other organ involvement, and classic histology, and when those are absent and the picture overlaps with cancer, surgery wins. The relapse pattern is the last piece and follows the mechanism cleanly. Type 1 relapses in a third to a half of patients because the underlying disease is a chronic systemic plasma cell disorder that prednisone controls but doesn't eliminate, so rituximab is the steroid-sparing agent of choice for relapsing or steroid-intolerant type 1, depleting the B cells that are the plasma cell precursors, dosed at 1,000 milligrams on days 1 and 15 with maintenance every 6 months for 2 years, while type 2 rarely relapses because the duct-centric injury isn't driven by a circulation. So autoimmune pancreatitis divides on mechanism. Type 1 is systemic plasma cell disease, and type 2 a duct-centered process, and the demographics, imaging, serology, other organ involvement, histology, steroid response, and relapse pattern all line up behind that one distinction. Once the criteria are met, the steroid trial does the diagnostic and therapeutic work, with a response within 2 weeks confirming, and a failure to respond sending you back to exclude cancer, except when the differential with adenocarcinoma is genuinely unresolved from the start, where surgery comes first because empiric steroids cost the resection window. The next episode takes the other diagnosis worked up through the same endoscopic ultrasound and fluid pathway, the incidentally discovered cyst, told apart by whether its epithelium is mucinous and whether it communicates with the duct, with the surveillance frameworks for the mucinous ones. For the full chapter, the practice vignettes, and the topic tag question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 3 of 5 of chapter 26, and I'll see you in the next one.